Welcome back to Mapping Healthcare in Davis, California, where a medic with a map explores healthcare around the world, highlights people who improve it, and shares what we can learn from them. This is your host, Dr. Sheikh. You're in a bustling hospital ward in Kiambu County, Kenya. It's loud and crowded. You see a mother who has just gone through a difficult C-section or cesarean delivery, but because the hospital is so full, she's sharing a single bed with another woman and their newborns. 4 people, 1 bed. A doctor whose shift ended hours ago sees a mother in active labor. He doesn't walk away. He just throws his scrubs back on and helps her deliver her baby. It's a world where maternity care is free, but the system is sometimes bursting through the seams to make that promise a reality. On today's episode of Mapping Healthcare, we're looking at the story of Kenya's free maternity policy. To understand where we are, we need to look back. Kenya's relationship with user fees, basically the money you pay at the hospital gate, has been a bit of a roller coaster. Right after independence in 1965, the government abolished these fees, but by 1989, they were back because the economy was struggling. In 2004, a 10-20 policy was introduced to make primary care affordable. This replaced variable medical user fees with a flat low registration fee of 10 Kenyan shillings at outpatient public clinics and 20 Kenyan shillings at inpatient hospitals. But even those small amounts were barriers for the poorest families. In 2007, there was an attempt to make uncomplicated births free, but it never really stuck. Then on June 1st, 2013, on the 50th anniversary of Madaraka Day, the national holiday that commemorates Kenya's self-governance from its past as a British colony, the newly elected president announced that from that day forward, maternity services would be free in all public health facilities. The goal was to bring down the toll of over 6,000 maternal deaths and 35,000 stillbirths every year. But this was a political directive that hit the hospitals before the infrastructure was ready. There was confusion about what was covered. Was it just the delivery? What about prenatal checkups? In 2017, the policy evolved into Linda Mama, which means Protect the Mother in Swahili. This program was run by the National Hospital Insurance Fund. The big change here was expanding the benefit package to include care before the delivery, the birthing process, and care for the mother and baby after that for up to a year. They brought in the private sector and faith-based hospitals so mothers had more choices and public hospitals weren't so full. This sounds great on paper, but when the cost barriers were removed, something else happened. There was a nearly 100% increase in deliveries at birthing facilities, in some areas almost overnight. But they didn't have 100% more nurses or hospital beds. There was one case where a mother followed every instruction, came to the hospital on time, but because the hospital ran out of blood and the generator failed during a blackout, she delivered in the dark and tragically passed away. The service was free, but the system lacked the resources to save her life. Then there's the issue of reimbursements. Hospitals were supposed to be paid by the government for every free delivery, but these payments were sometimes delayed by up to 8 months. Nurses had to ask mothers to go out and buy their own gauze, gloves, or syringes because the hospital simply didn't have them. It's a tough spot for healthcare workers. They're motivated because they're saving more lives, but they're also slowly burning out and sometimes take their stress out on patients. Today we're joined by Dr. Lydia Okutoyi, an obstetrician and gynecologist and a senior medical specialist at Kenyatta National Hospital in Nairobi, Kenya. We talk about how the free maternity policy looked like for the people on the front lines when it was first implemented. The views expressed on the show are mine and those of my guest. So, Lydia, welcome to Mapping Healthcare.
Thank you.
Today we're talking about one of your papers where you studied the free maternity policy in Kenya, and this was announced as an executive directive for immediate implementation. Essentially, it caught hospitals by surprise without a chance to adjust their staffing or budget. And this is something that health systems around the world face, where there is a policy change around payment policy for healthcare services, but perhaps, attention, readying the staff for that work. So if you were to travel back to the day that directive hit the national referral hospital that you work at, what did that sudden change feel like for the frontline doctors and for the nurses?
Government was wanting to address the gaps with regards to access to care. And at that point, I think our maternal mortality was much higher than what we are now. And so the idea of having an intervention that will help us access, that every other woman can access care without thinking about the finances was very important. The only challenge is that we did not look at what did we have. We did not address how did we prepare the facility, the human resource. And remember, there was a balance. Kind of patients were accessing care, faith-based organization. They were also getting care from other non-governmental. So the policy, it came and it brought some bit of restructuring in who goes where. And so it was important for the policy to be done, but the how, we think it could have been done better. We could have involved, government could have involved the frontline healthcare workers or the leaders of the institutions, and then also to prepare so that we don't suffer.
And, these decisions, they have implications at various layers. So let's talk a little bit about Kenyatta National Hospital. It's the oldest hospital in Nairobi, and it was established in 1901. And it's a public tertiary referral hospital for the Ministry of Health. So your data shows that hospital deliveries literally doubled once this policy went into effect. And that created a massive mismatch between the number of patients and the existing infrastructure. So, can you paint a picture for our listeners of what it looked like in the wards, right, at the front lines, when mothers were sharing beds and privacy was, as one hospital staff person you interviewed put it, remarkably reduced?
Yeah, at that time, the maternity actually got a surge, up to including patients who had been booked for electives in the other private hospitals. I remember I did one of the calls around that time, and so we had a sharing of beds, we had burnout, we have reorganizations to have other nurses, some who are midwives, some not, to come and support reinforcement, and the normal utilities that are used in labor ward. So all those need to be sterilized much more often. We have 2 dedicated theaters for labor ward in Kenyatta up to now. Those who were a shadow, we needed to have others. And remember, these 2 dedicated theaters are 24-hour theaters. So we had a need for more staff, including anesthesia coverage. And when also you have a surge, and you're having more deliveries, you're likely to have more complications. So more need for the products. Blood is one of the most essential products. So all those utilities were stretched. And because we couldn't have all those women being supported, also outcomes were not 100% what we would have wanted. Yes, they arrived in the hospital, but we were asking what would be the quality of care, because remember, they have also come as referrals. Are those who've come primarily to us, and others who've gone to other spaces because of financial possibility of having care without pay. Yeah, so that was a great challenge for which I think the country learned. Further to that, we had our demographic health survey that confirmed we increased hospital delivery. Skilled birth attendants had gone up, hospital delivery had gone up, but our maternal mortality did not improve commensurate. There was some slight improvement, but it wasn't commensurate to the increase in access. And so there was the question of then what quality of care is being provided. And so it became apparent that the quality of care is not just because of what the facility does, but all these other referral mechanisms, the health-seeking behaviors from community, that all that will finally affect the quality of care that will be given. And so it gave us now a different challenge. In the previous years, when we talked about maternal mortality and the challenges, they were about what they were calling the 3 delays. So they were talking about delay in coming to facility and delay in transportation, then the delay in getting quality of care. But now we have narrowed all the other delays and have more than 89% come to facility, but still you are not making a dent on the bad outcomes for both the baby and the mother.
As I was reading about your experience and listening to you, I was thinking about the fact that a policy might be introduced, but a lot of the heavy lifting and implementation of that policy goes on in the front line. And that affects frontline healthcare professionals who basically are overstretched to try to keep up with the demand, right, without the resources. So, what I found fascinating in your findings is that despite the many challenges, including burnout, high workloads, and fear of litigation, most healthcare professionals still rated their job satisfaction quite high. So, how are these teams able to maintain such a strong sense of morale, of teamwork, while, as they put it, living one day at a time in an overstretched environment?
A big factor is with the leadership, and leadership starts in both ways. There's the frontline leadership. I think the maternity unit at that time and even now, but I remember that team, they were very engaged, and the leadership among the midwives and the obstetrician in charge. I mean, there was good communication. This is at handover. They'll make sure they are truly addressing their challenges, because once the nurses are comfortable, the gynecologists will be comfortable. During the round, you'll see that they have taken care of the needs. And so the hospital administration gave them the support in terms of increasing some casuals who support movement of the patients, including even up to having locum. Those are the time that even would get locum nurses. And so that stretch and reorganizing. So the chief nurse would reorganize the nurses. So part of what makes work to be joyful is serving. And if leadership enables you to serve, then amidst a place where it could be really challenging, that you could have burnouts, the issue of collegiality and knowing that you can be allowed, it's called a bit of autonomy to reorganize yourself and give suggestions. So that kind of leadership was still there at that time when we were having a stretch. Labor ward is usually this very delicate place because things can go right or very wrong. And so many administrators literally in this moment, they do the Gemba walks. They visit the space and just see, and we've improvised, we've added more beds within the corridors of labor ward. Our labor ward has been a 45-bed labor ward. By that time, you could get up to 70, 80 mothers around. And we also, being a referral hospital, yes, we're getting those deliveries, but we have those special cases, the ones who have cardiac disease in labor, the ones who can't be managed elsewhere in terms of a public facility. They need to come to our facility. And so they may not be in transit. They've not just come to labor ward to go to another facility, but they will need to be stabilized and go to the ward. And so they don't have the few hours of a normal mother in labor or a cesarean. And so something that helped was the collegiality and for fulfilling they were a team. Usually there's an extra step taken, like providing a meal or bread or milk, which routinely we don't like always feed our staff, but for those high intense areas. So during such a time, those rations are increased, just making sure people have energy, they're hydrated. And then also the chief nurse was very keen that the coverage, whether it's weekend or night, is done well and would pull resources from other less intense areas. So that was useful. Then the pharmacy support also was provided by the institution. And in case there was any challenge, there is somebody who covers the CEO's office for the night. And so that team can be called anytime, and they have both procurement, supplies, pharmacy, facility. So the challenges are usually as technical as provision of care and as small as ensuring the place is clean, that we have enough cleaners to support the decontamination and to help everything go to the central sterilization unit, because it will now become like a conveyor belt, and the frustrating issues are not big issues. They're just about, do I have enough supplies that my medications are okay? The intern has arrived, the resident, the consultant has come for the evening round. And so that continued happening at that critical point. And I think many women were saved, but then also, unfortunately, we also had some outcomes that weren't as good, just because some also come late, and then also there was a stretch. So there were lessons that were also learned, both in our facility and at national level.
Yeah, and so as you were telling me about your experience, it's just so many layers here that need to be taken care of. Unless the frontline leader, the administrator at the health system, is keenly attuned to these rapid changes and is willing to be flexible and nimble. And, there's 24/7 coverage to handle these issues on the fly. I can see how capacity to handle the infrastructure can fail. So you spoke about so many things that came together when the frontline administrators were deeply involved getting the critical medications needed. You mentioned Gemba walks, where you had the leaders on the floor experiencing what the frontline staff experienced versus, being in their offices. So that's a critical concept in healthcare improvement. And you also mentioned, try to mobilize your internal resources, but also getting external resources. So you spoke about locum nurses that you had come in, and these are temporary or contract nurses who fill in for permanent staff in these critical times, staff shortages or high demand. So lots of moving parts here that can't be taken care of unless the hospital administrator is at the front line. So really important point there. And, this really made a difference. In the past, many mothers were essentially, they were detained, as the word used in your paper, in the hospital for weeks because they couldn't afford their bills. But this policy changed that issue overnight. So beyond just medical care, can you share how this changed toward quicker hospital discharge, leaving the hospital faster, and better access, transform the emotional state, the emotional experience for families coming through your doors?
Being allowed to go home for those who otherwise would have had a challenge in paying the cost of care would really give significant relief for some rooms that would otherwise have been used as a place for waiting for a bill, waiting for the family to put together the cost of care and just pay. And some would pay in installment. There was a lot of relief even among the staff, because remember, as a nurse and a doctor, you didn't want to have a ward, and a proportion of it, they are not people in active care. In terms of, you have to feed them, you have to account for them, and to ensure they're also well. And then we all are aware that hospital is it's a hazardous place because they're sick people. So it means if you're feeling better, you should recover at home, because it's likely that the risks are lower. Because here you're having the healthcare workers interacting with the very sick. And then now, if you are well, and especially with a neonate, it is better to be at home. So we were glad that the mothers would go. And then also for the hospital, it was sustainable that we would be reimbursed. So also it becomes a win, because we want to be sustainable, to be able to buy the gloves, to buy the medicines they require. And so that was an approach that would have sustainability and enable us to continue giving that quality of care.
Your research also highlighted a major hurdle that you touched upon. The government's reimbursement for these services is often slow, sometimes delayed by up to 8 months, and it doesn't always cover the cost of complicated cases. So, based on your findings, what needs to change in how we fund these programs at the policy level so that free maternity care doesn't end up bankrupting the very hospitals that provide it?
Since this is in the spirit of universal health coverage, that we are addressing maternal health, which is a human right, so that they can access quality of care. And so when there is clarity on how they are onboarded, like how do we have even a girl who has not got into the age of getting a national identification yet into the system? So those were challenges then, but now they're being addressed. So that clarity that we know that this person has been fully registered. And once they are registered, then the documentations on delivery are then clearly stated as such. Those who needed critical care, those who needed dialysis, more intense care, and those are the ones likely to come to our place, those who stayed longer than expected. So there was just a fixed amount for a delivery. And for example, if somebody came after having had their delivery elsewhere, and so the birth notification was given from that facility, then this other care, which is very much needed, would find it challenging to be reimbursed. But those have been teething problems that have now been well articulated, and we hope that they will be considered in this current arrangement that we have. So we find that institutions may be challenged in giving what they ought to because maybe they don't have the resources. And so resources including the consumables and blood and medicines should always be available. And the other approach is the aspect about things that cannot be charged because we're in public sector. The human resource, we talk of facility preparedness, and that includes the human resource. So are they prepared to take care of a normal delivery? And are they prepared to recognize and take care of a complicated delivery? And so those skills need to be refreshed. And the midwives, if they're trained in emergency obstetric care, then we know that we are on the right path. And so those are some of the aspects that I think hospitals struggle to, because it's at a cost, and they struggle to update that, yet the funding does not cater for that. And so I'm happy that in this new initiative that is coming, the country efforts are articulating the skills gap and ensuring that there is correct numbers, but correct skills and training. So I'm curious to see how that will be funded, because that is a cost implication that we cannot just expect the hospitals to do it automatically. We need to have a strategy.
And to wrap up our conversation, we have spent a lot of time discussing the high stakes environment within the walls of Nairobi's National Referral Hospital. And Nairobi is a vibrant, multi-layered city beyond the hospital gates. And your work is deeply rooted in its heart. So for someone who might be visiting the city for the first time, perhaps inspired by the dedication of the healthcare teams you've introduced us to, what are some of the experiences you would recommend they seek out?
Okay, so Nairobi hosts the only national park that is by the city, which is within 15 minutes drive from CBD. And we have the Nairobi National Park. We have a few sanctuaries that are like refuge areas for animals that need help. Like we have a giraffe center, and then we also have an elephant sanctuary, another national orphanage that's just by the national park that have a few animals that need help. But then we have them in the wild, close to Nairobi City, the Nairobi National Park. That is something that somebody should not miss. Then you can experience culture at the Bomas of Kenya. There is how we lived, our tradition, our food, the dance, the attire we share with Tanzania, the Maasai culture. And then if there is more time, you could go to the Mara and experience the wildebeest migration, if that is happening. If it is not during the season of the wildebeest migration, still you can see the wild animals in the Mara. Otherwise, there are many other conservancy in Nairobi, and they are within not too far, like a day's trip, a savannah, see the ostriches. Kenya has all the climate from the forests to the grasslands and to the semi-arid areas. And I think Kenyans are basically happy people. So being greeted just for the purpose of finding out how are you. Yeah, people, they're warm people. We call it ukarimu. They're warm people and welcoming.
A beautiful, vibrant place, and with people that are warm and deeply connected to compassion and taking care of others. So, thank you so much, Lydia, for your time. I really appreciate your dedication to your work and to the science of improvement and making sure that complex policies are implemented well at the front lines of clinical care so that they are set up for success right at the time they're introduced. So that was Dr. Lydia Okutoyi telling us about the price of free in the translation of governmental policies to frontline medical care. In 2005, the Kenyan government transitioned the Linda Mama program to a rebranded program, Linda Jamii, Swahili for Protect the Family. This program was run under the Social Health Authority. With this, the program expanded from a maternal health initiative into household-level health coverage that also included spouses and children. The experience of implementing maternity care in Kenya shows us that a policy window, like an election year, is a powerful tool to push through major reforms that would normally take decades. But a big lesson, you cannot address the demand side, in this case the mothers, without fixing the supply side, in this case the hospitals. If you tell people they have free or low-cost access to care, you need to have enough beds and clinicians waiting for them. As we wrap up, here are 3 things to take away. First, free isn't always free. Removing the price tag at the hospital entrance is great, but if mothers still have to buy their own supplies or give birth in overcrowded conditions, we still have a barrier. Second, frontline implementation is just as important as policy formulation. A great policy on paper can fail if reimbursements are erratic or if frontline clinicians, hospitals, and patients aren't involved in the planning. And finally, invest in the people. Kenya's clinicians were doing heroic work, skipping lunches and pulling double shifts. But heroism isn't a sustainable health strategy. We must support the well-being of clinicians if we want to ensure high-quality care for mothers. Thanks for listening. This was your host, Dr. Sheikh. Connect with me on Instagram at Mapping Healthcare. If you enjoyed this episode, please leave a review. It helps get this show in front of new people.